this is Tony.
This is Paul coming at you from the Friends for Life podcast.
And we're go.
Hey everybody, welcome back to the Friends for Life podcast here on YouTube. Today we're talking with our very special guest, Dr. Craig Escude of Health Risk Screening Inc., or HRS for short. Let's dive right into it and learn more about HRS and Dr. Craig Escude. Before we get too detailed into the nitty-gritty of the field, why don't you give us a little background about yourself and how you kind of went down the path to become a doctor, and then how you got involved with the field of, MRDD and things of that nature.
Sure thing. First, thanks for having me. I really appreciate the opportunity to be here with you. Growing up, I just was always interested in science and medicine, and it just seemed very natural. I grew up in a very small town, didn't see a lot of different career opportunities, I guess. And when you're into science, it seems like, well, being in the medical field seems like a good career. So I kind of went down that road, went to college, liked it, did well in it, and said, well, I'm going to go ahead and go to medical school. Went to medical school. Quite interesting, I will say. Medical school is challenging.
Yeah.
And
I've watched enough TV shows to know that much.
Yeah, there's probably some truth to some of those.
Yeah.
But as time went on, towards the end of medical school, you kind of have to decide what field you want to go into. I had initially thought I might go into OBGYN, but then realized, that wasn't quite for me. So I decided to go into family medicine. So after that, and I did my medical school, by the way, at LSU in New Orleans. And then I moved to Mississippi and did my residency training in family medicine at University of Mississippi Medical Center in Jackson. When that kind of period ended, it was about time to figure out, well, what am I going to actually do once I get out of medical school? And one of the things that's kind of nice in family medicine is that there are a lot of options. I did start right out of residency working at a federally qualified health center and practiced there for 4 years doing regular general family medicine. Wow. But it just didn't quite, it wasn't something that I really saw myself doing for the next 30 or 40 years. Mm-hmm. While I was in residency, we spent a little bit of time at one of our state mental hospitals, Mississippi State Hospital. And I kind of liked it. I enjoyed the interactions there. I enjoyed the patients that I saw there. It was different than regular family medicine, but I was still able to practice medicine and providing healthcare for people on the campus of this program. So I decided to move into that as a full-time position. While I was there, they needed some help across the street at this place for people with disabilities. I'm like, what's that? Never heard of that before. So I went across the street to this place called Hudspeth Regional Center and found that this was a facility for people with severe and profound levels of disabilities, and they needed some additional physician, help. So I'm like, sure, I'll start working here a few hours a week. And it just really stuck with me. I really enjoyed it. I felt it was much more of a calling for me. So I transitioned into being the medical director of that program and did that for a little over 20 years. So I kind of came upon the field in a roundabout way, not directly. It just kind of happened. It was quite eye-opening, I will say, because one of the things that I learned very early on was that I was not prepared. I was not prepared in medical school or residency to provide healthcare to people with significant levels of disability and complex medical conditions. And it wasn't that I didn't understand the disease processes. We know how to treat pneumonia. We know how to, what constipation is, all of those things. But it's the different ways that people with disabilities communicate. the different ways they might express their symptoms. You have to take a different approach. I'll tell you, one of the things that I learned or I heard very frequently from staff members when they identified that a person might be becoming ill, they would just come up and say, he's just not acting right.
Wow.
And that's about all you get. And as a physician, you want to ask lots of questions, and you don't always get the answers. And they're like, well, I don't know. He's just not acting right. Well, what is he not doing? Well, normally he looks at me, and we'll kind of have some facial expressions when I talk to him, and now he's not doing that. I'm like, wow, okay, what disease is that? And when you don't have that understanding of what are the most common things that can occur, or how to dig a little deeper, you feel very at a loss.
Mm-hmm. Wow.
So it was pretty challenging. And unfortunately, as I've gone along in this field over the years, I realized that I am not alone. Most physicians have received very little training in diagnosing and treating conditions in people with intellectual and developmental disabilities. That includes nurses and dentists and physical and occupational therapists. Really, in the healthcare field, there's just not enough training and education. So I learned a lot of things, I would say, the hard way, and I learned them from nurses and direct support professionals who worked at that program, at the facility for many years, and had learned those things the hard way too. And thankfully, I had some great nurses who guided me along. And I learned a tremendous amount about taking care of the health needs of people with disabilities during that time. So how did we get where I am now, which is no longer doing that? Yeah. So back in 2011, as has happened in many states, the Department of Justice came into the state of Mississippi to look at, the support system for people with disabilities. Mm-hmm. And we were, I guess you could say, encouraged to move towards more community-based supports and less reliance on large group facilities. And most people who have worked in this field, have seen that transition or understand that transition and the reasons why and why it's better. But my first thought was, frankly, people are going to die. People are going to go out. People who with the types of disability, the level of disability and complex medical conditions that I was taking care of, if they moved out into a community setting and had to go and rely on community-based clinicians and hospitals for their care, they would not do well. And I knew that because if they had come to me before I had learned, all of this, I wouldn't have been able to provide the best care for them. Mm-hmm. So I made it my mission at that point. I saw the writing on the wall. We were going to be moving people out into communities. And so I said, you know what, I'm going to do whatever I can to try to educate clinicians and support clinicians in community settings so that when people go to their offices, they have a better idea of what to do when the staff member walks in with them and says, he's just not acting right, or she's just quit eating. So I created a program in Mississippi called the DETECT program, which is the Developmental Evaluation, Training, and Educational Consultative Team. So I began doing talks at medical conferences, nursing conferences, any type of health-related conference I could get into in the state on the basics, just the basic things about healthcare for people with disabilities. I was able to secure a large grant to be able to create this program. So we were able to create a consultative clinic where we can provide consultations for people out in communities to come in and maybe get an opinion or a second opinion or an additional opinion or help from people who understood what was going on. So we were there really to provide education, training, and support to healthcare providers in the state.
So
Any
it sounds
questions?
to me, well, it sounds to me like you really have had your hands full. Like, I mean, you've been here in the field for quite a while, and now you're making changes in the verge, well, in the aspect that we need it as DSPs and caregivers. I've been in those doctor's appointments where the physician was not able to accurately diagnose the individual, kind of because the physician was too scared to even diagnose the individual.
Yep.
And so I really see the need for your programs and your teachings and everything else. I just wish we had more of it in in my sector of the world.
Well, I'll tell you, Tony, and that kind of segues into where I am now in my career. I want to say one thing, though. This gets mistaken a lot, that doctors really just don't care, and I don't think that's the case.
No, it's
Physicians
not.
really do care, but they just were not provided with that type of training, and they don't understand. I'm not a cardiologist. I don't understand all the nuances of cardiology. If someone came to see me with a very complex heart condition, I wouldn't really know what to do, and I would feel very uncomfortable if I was supposed to take care of them. So it's a matter of training. It's a matter of education. You talk about DSPs and all, it really does take a team of people to understand what's going on sometimes and to provide the best support.
Definitely.
So as I was moving along in this career, I became aware of something called the health risk screening tool. And what that tool is it's a web-based tool that's designed to screen people with vulnerabilities. It's mostly used in people with intellectual and developmental disabilities, but it's applicable for people who have some difficulties because of aging or traumatic brain injury. But it's designed to screen someone and then to identify specific areas where there's increased health risk. And so you get areas of health risk, but what's even better than just knowing risk is knowing what to do about it. So once the tool identifies health risk, it provides action steps to take, which basically directed the support team, on actions that they can do to help reduce risk, as well as training. So it can help make sure that people are trained to identify that person's specific health risks and what to do if they should see early signs of it.
All right, can you give us an example?
Yeah. So let's say, we know of one of the types of behaviors we see sometimes is what's called pica, where people eat things of non-nutritional value. They may pick up things off the ground or whatever and eat them. And
if I can interrupt, that is a very difficult thing as a DSP to try to combat. I am telling you, to have to try to constantly redirect someone with pica not to eat, let's say, a screw or a piece of confetti. It's tough.
It is very tough. And you can't always do that. And unfortunately, in my career, I've seen some bad outcomes from some of those incidences.
I'm sure.
But one of the things that I didn't know this until much later on in my career, but pica is associated with undiagnosed gastrointestinal problems, meaning reflux.
Whoa.
Yeah. And so what the tool does is it asks very, very simple questions. And it's not something meant to be administered by a nurse. It's actually meant to be administered by direct support professionals. So it's anyone who knows the person the best. So it might ask questions like, does this person have a pica behavior where they put things in their mouth? Does this person wake up in the middle of the night crying or agitated? Does this person become agitated around meal times? Well, let's say you answered yes to those questions in different areas. Well, the tool kind of has some sense behind it. And it says, okay, it's got these things. These things point to an undiagnosed gastroesophageal reflux condition. So then you'll get, so then you'll get then you'll get a what we call a service consideration that will recommend to the team, hey, there's some signs here that this person might have reflux. If you should consider taking them to a physician to look for reflux.
Okay.
Well, that's really nice and very helpful. And I can't tell you how many times we have diagnosed, the tool has picked up on this, the team has taken action and they've taken them in, they've had reflux and they get treated for it and the pica behavior stops. Now, It's not all the time because it's not 100% caused by that. But a lot of the time it is, and it can be. And you might wonder, why is it related? Well, think about it. If you have acid that's refluxing, okay, it hurts, it burns. Now, if you swallow or drink something, it washes that acid back down. And the person who maybe isn't able to verbally tell you those things might say, well, gosh, every time I eat something, I feel better. So I'm going to eat this and I'm going to eat that and I'm going to eat this, or I'm going to suck on a rag or a sock or something like that because it increases salivation and helps wash that down. So that's how those things are related. So that the tool can help point people to a service like that can relieve suffering and improve the person's quality of life, not to mention the risks associated with, esophagitis and chronic reflux and things like that.
Doc, since you say that, like it takes me back. I think the first time that I ever had like acid reflux or heartburn was actually not too long ago. And Paul is kind of laughing now because I literally thought I was having a heart attack. Like it was the worst feeling ever. And I mean, I'm sitting here, I'm touching my fingers and trying to make sure my chest isn't hurting as much, but it was like a super scary experience. So thinking about, how it felt for me, and I'm a person who can, express my issues at least much better than a lot of the individuals we serve can at times, and to think about the desperation that they're having and that they're looking for a relief. So, I mean, I just love how all of that comes together. I mean, it helps me more and it helps our staff more when they watch and understand, like, there's so much more going on than what we can really grasp. And sometimes we need to look at it from a personal standpoint to even comprehend what they're going through in their lives.
You're exactly right. And let's say you weren't able to communicate what you were feeling with someone, but you were having intense pain. What might you do? You might hit yourself. You might throw things. So we see behaviors. We hear the term behaviors a lot. Oh, he has a lot of behaviors. Well, I'm actually getting ready for a webinar that we're going to do through our company, which is called Actions Speak Louder Than Words. And it's behavioral manifestations of common medical conditions in people with disabilities. Because so many of the behaviors that we see can actually be a person communicating to you that they're having discomfort. And it can be specific types of discomfort. Certain behaviors point to different things. Some of them are more general, but it's really important for people who work in this field to understand that people don't enjoy banging their head on the wall, or they don't enjoy, yelling and screaming and fighting. There often is some other reason for that. Many times it's medical. It could be environmental or social as well. But we don't always think of that. What do we think of first often? We think, oh, that's some psychiatric problem. We need to send them to the psychiatrist. And then they get put on a psychotropic medication, which has its own risks and side effects. And maybe it'll help because it sedates them. But is that really what we want to do? Do we want to sedate somebody who is having severe dental pain from undiagnosed abscesses, and that's why they won't eat, and that's why they're agitated, and that's why they put food in their mouth and they spit it out because they're in so much pain? And we're saying, oh, look, they're just not behaving well. Let's put them on a medicine to sedate them. That's not what we would want for ourselves, and we shouldn't want that for people with disabilities. And I don't think we want that. I think we just don't always know what to do. So we end up.
It's a frustration.
Yeah.
And I feel it. Sometimes I hate to do this, but sometimes it needs to be said the way that I'm going to say it, that it's just like a child or a close family member that you're caring for. You know, in order to help them go to another place, you almost have to keep them away from what you know will hurt them. Now, granted, we have teams of such in the field that we're in that we don't have to necessarily take those steps without, you know, everyone saying like this is the best step. But as difficult as it is to raise a child, it's even more difficult when you have a team of 6, 7 people trying to tend to one person and everyone may not see eye to eye. So that's how I correlate a whole lot of things when I think about the whole team structure and how we can make it better, because you, a lot like myself, I'm sure we've had some difficult cases, and you know, the quote unquote ordinary or easy fix never turns out to be that easy or an ordinary fix.
Very seldom.
You know, so that kind of segues me into something, if I'm not interrupting you, but I want to know, like, tell me, like, what is your best moment in either direct support or even in the medical field, and your worst moment in direct support and or in the medical field?
Wow.
Yeah, I want to get deep.
Yeah, you're really going deep here. So, you know, a lot of things are mixed. I'm going to tell you, I think I'm going to tell you 2 stories. I think my worst moments always seem to relate to abuse.
Gotcha.
People with intellectual and developmental disabilities are 7 times more likely to be sexually abused. And abuse in general of all types, they're much more likely to be abused. And you never want that to be what happened, why somebody got a particular injury or has this particular, you know, mark on their body, or why did they become so withdrawn? Why do they, every time a guy with a bushy beard like Paul there walks into a room, do they start screaming and yelling? And you know, as we learn things, we start to learn what things might point to abuse. And that's one of them. If somebody becomes agitated when someone with a particular physical characteristic comes in a room, it may not mean that person's the one who's doing it, but it may mean somebody who looks similar to them might be abusing them. And I always hate when that proves to be true, because it's very, very upsetting. It might be a staff member, rarely. More often, it's somebody who knows the person well. It may be a family member or a neighbor, and those for me are the worst moments. It's terrible when I think about somebody taking advantage of someone, you know, with vulnerabilities like that. Very, very rough times. Now, I'll tell you another story that I guess just really, really sticks with me. And it's very, very humbling from my standpoint, but I'm so thankful. And it turned out to actually be a great moment. So
that's what we like to hear. I love to hear great moments.
Okay. So we had this person that we were working with who all the years, all of us had known her, and she had been, you know, living in the system for many years. She always was a very, very picky eater. Mm-hmm. She would bite her hand frequently, which is a behavior that we do see. But it seemed to be something that she had always done this for many, many years. Well, she had times throughout her life where she had a bad tooth here or there. She might have some dental work done. She was very resistant to dental work, very resistant to having her teeth brushed, to any type of oral care. But it finally got bad enough, and the dentist said, she has quite a number of teeth that are just not doing well. It's time really for us to discuss, and the team and her family to discuss having her teeth removed. We call it, full mouth extraction, which is not something we like to do at all. But it's like, gosh, she's got a lot of dental problems. This might be, some of what's going on. So the decision was made, and she went in and she had surgery. She had all of her teeth removed. After she healed up in about 2 to 3 weeks, she quit biting her arm. She smiled and laughed instead of hit people. And she started eating all of the food on her plate.
What, man? Wow.
So what does that tell you? That tells you that for years and years and years, she's probably been suffering with pretty bad dental pain.
Definitely.
And finally, when she had all of that removed and it all healed up, she was a new person and a new woman. And to be able to make, I hated that it lasted many years. That's the difficult part of it. But to be able to identify things like that and look at those behaviors, even if they've been around for a long time, and then to say, you know what, this might be going on, and you identify it and you take care of it and you treat it, and they start laughing and smiling and interacting and quit self-abusing themselves, that's a win. Yes, it's a win. It's a win for the team, but it's a real win for the person. And that's who we're here for, And so, things like that are just amazing to see.
Yeah, and that's what you want to see, because a lot of the time you only get to see some of the bad stuff, and like you said earlier, people talk about, oh, they're having behaviors, oh, they're doing this, oh, they're doing that, and all you see here is bad things. It's good to hear a win every once in a while like that. One thing I noticed is you've written 2 books that are, you're using to teach, you're using that you're selling to kind of show people the right way. What was your inspiration for that, and kind of what is the thoughts behind these, and what do they kind of offer to people?
Sure. So I was telling you, back up just a second, and I'll touch on those too. But I was telling you how I was working for the state, and I learned about the health risk screening tool. Well, I thought so much of this tool that I really wanted to get to know more about it, and I learned about the people in the company. And then I learned about the company itself and their mission and how the tool was developed. And it was very much in line with the things that I went through. And the company was at a point where they were looking for someone to join the team at my level. And so I was able to retire from the state about that time as well too. And I decided to move into the role as president of health risk screening. And it was and still is a very natural fit, because what our company is about, it's about reducing health risks, removing health risks, replacing health risks, basically replacing risks with health and wellness in people with intellectual and developmental disabilities. And that's what we do. So the health risk screening tool is the biggest component of that. But a couple of other things we have are what you mentioned. So we have, I was very inspired to write the book, Clinical Pearls in IDD Healthcare. And to just to let you know, for people in the medical field know what a clinical pearl is, but it may not make a lot of sense to people outside of it. A clinical pearl is basically a little tidbit of information that usually comes from practical experience. And so you can have clinical pearls in any field, but what I had learned, so many of these little pearls, little tidbits of information through the years, that I wanted to put it out in a format that's easy to read, that makes sense, that is applicable from everyone, from direct support professionals. They can pick up this book and read it and gain an understanding of some medical issues, all the way up to physicians. because physicians don't necessarily have that background or that training, and they can pick it up and look at it and say, wow, okay, I see how this relates to these conditions now. And the book has been very well received. People are using it in ways that I didn't even think about, besides just using it as training for staff in organizations and homes. They're using it to bring a page of it, and we give permission for people to copy a page, to take it to a clinician's office to help orient them to a particular condition. And they're also using it for families, because a lot of families, you know, if you have a child who's born with a disability, you have not only a disability to learn about and how to support that child, but you have a whole system of care and support that most of us don't know anything about unless we've worked in the field or we've had a family member. Yes. So this book is being used to help family members have an understanding of some of the medical conditions that they either are dealing with or might have to see or deal with in the future. So that's that resource. The other thing, while it kind of looks like a book on paper, it's really not. It is an electronic learning course. It is a web-based e-learn course, and it's called the Curriculum in IDD Healthcare. That fits into a number of offerings that we have in our company in terms of e-learn for people with, or for support people who work in the field of healthcare or support in general for people with disabilities. So there's a term in the field called the Fatal Five. The Fatal Five are the 5 big conditions that we consider preventable causes of morbidity and mortality or death in this field. And that's something that, if you want to talk about another time, we could go into each one of those in depth and talk a lot about those. But they're basically it's seizures, bowel obstruction or constipation, dehydration, sepsis, gastroesophageal reflux disease, aspiration is the other real big one. Things that we consider preventable causes. So we have e-learn programs in our company that are used to train people at all levels. We have some geared towards direct support professionals that teach them about these conditions and how to recognize them and what to do about them. We have them at another level that's meant to train nurses. So it's a little more clinically oriented and has a little bit more information. Well, we also have some other courses used to train, again, those same groups on different things like choking and person-centered thinking, which is another whole other topic we could talk about one day. But one of the things that was really my personal mission that I brought to the company was to provide the fundamentals of IDD healthcare to physicians. So the curriculum in IDD healthcare is an online course geared specifically to physicians and to nurses, to provide them with the fundamentals that we all should have learned in medical school. We just released this a few months ago. We have piloted it at a medical school, and the medical students gave us tremendous reviews, and it looks like they're probably going to publish it. So we're looking to make this available to medical schools and to medical students. We've had there's an organization in New York that we work with, that we partner with, they provide IDD specific telehealth services. And as you probably are aware, telehealth has surged in popularity because of COVID, which is a whole other thing we can talk about for hours. But they do IDD specific telehealth, and they wanted to train their physicians. Well, we have this curriculum is the only thing out there like that. So they use the curriculum to train their physicians who provide IDD telehealth, that's the purpose of the course, and it is filled with practical, immediately usable, and implementable information. It's not a bunch of medical jargon. It's like, this is what you need to know.
It's super awesome that you even mentioned the telehealth also, because right before COVID happened, last year in the end of 2019, we were putting some things together with another organization who they're getting a grant for more of the telehealth type of systems. And we put in an order for some, and we were like hoping like, hey, they're going to be in, but then COVID like kind of threw everything off. God knows what's really going on now, but now people are definitely seeing the need for it. The expression of not having to leave for simple things at times that we might think are more valid at that moment, but it's like a tingle in my back to know that you're probably a huge part of the reason why they're able to help more now. You know, you giving the curriculum out there is a big help for this field to help our individuals who can't or should not always have to go to the ER, or an urgent care unit.
Well, that's become my mission and my passion, is to help people or help people to learn things that I wish I had been taught way, and didn't have to learn the hard way. But ultimately, because I believe that anyone blanket, but anyone, including people with disabilities, should be able to present themselves to any physician's office in any hospital and get a basic level of competent and compassionate health care.
Amen.
And that does not exist. I'm not talking about highly specialized care. I'm just saying that they should be able to walk into any family doctor, internist office, go to an emergency room, and everyone who works there should have a basic fundamental level of how to provide health care for people with disabilities. And it doesn't take that much. I mean, this is a 6-module course. And it runs for about 4.5 hours total. And we surveyed both physicians and medical students before they took the course, and then right after they finished the course, and they self-rated themselves on their level of ability prior to taking the course and their level of ability after taking the course, and how they felt that they could provide healthcare for people with disabilities. And they had the practicing clinicians had a 62% improvement in their ability. The medical students had a 107% improvement in their confidence just after 4.5 hours of this course. And that's huge, to be able to have that kind of an impact with just a little bit of training. And I know I've sat through many hours of medical continuing education training. And it's like, yeah, I know that. Yeah, I know that. Oh, I didn't know that little piece. Oh, yeah, I know that. Yeah, I know that. Yeah, I know that. You sit through this, you know the basic concepts, but most of what you learn in these courses are things that we were just never taught. So and that's the feedback we've gotten from it.
Yeah, I've taken photography courses that are longer than 4 hours. Probably got half as much info out of them. So that's pretty impressive, actually. Those improvement rates are like very high, because most courses do not rate that high. One question I always like to ask is say there's someone that wants to get into the field, someone that wants to maybe work themselves up to a position that you're at. What advice would you give to like a young person who's going into maybe med school or pre-med or something like that, and they want to take this course? What advice would you give them? Because you've been in it for a while now, so.
Yeah. So if we're looking at people who want to get into this from a medical standpoint, one thing that you're probably going to have to do is be an advocate at your medical school for this type of education. I'll tell you, there is movement toward requiring education in medical schools for regarding healthcare for people with disabilities, but it's not there yet. But this year, the dental accreditation program is requiring it in dental schools that they have some degree of training in dental care for people with disabilities. And so I'm hoping that it'll follow suit for in medical schools as well. But there's an organization out there that I've been a member of for years. It's called the American Academy of Developmental Medicine and Dentistry, or AADMD.org. They focus on providing they focus on moving forward education of healthcare providers of all types in this field. And so they have an initiative that's called the National Initiative or Curriculum Initiative in IDD Healthcare. And I didn't get that exactly right on the letters, but they are moving to implement curriculum in medical schools, and they have the beginnings of it in about 20 medical schools right now. And so the idea is to move that forward. But if you're a medical student, first of all, if you're at one of those schools, that's great. If you're not, though, talk to the dean, talk to the administrators, talk to your physicians there and say, look, we need to implement this. And that organization has some tools to help get more training into medical school. So that's one thing. The next thing is I would certainly try to immerse yourself in the field. Go to group homes, go to day programs, go to work programs, go to facilities if they're around where you are. Facilities have a bad rep, big facilities, and there are some good reasons that they have bad reps. But facilities are also and have been good things in a lot of ways as well too. And one of the good things is the larger facilities really focus on, or really not focus on, but really have the benefit of being kind of a training ground, like they were my training ground. And as all the larger facilities close, you're losing these training grounds for nurses, for DSPs, for physicians who work in this field. And that's why, honestly, it's so important for a company like HRS to be out there, because we focus on providing people who work in the field with the training that they need and with the support that they need to identify health risks and to learn how to prevent them and to mitigate them. And as facilities close, you're losing those grounds where people have received that type of training.
And you know what? That is a great point right there. A lot of us forget about how the facilities can actually offer that connection first and foremost, not only to the field, but to the individual. A lot of the individuals that I service today and the ones that I grew up servicing were through facilities at some point. And although we're more into the residential side of things now, and that's what everyone is trying to get into, some people, it is a little more difficult for them to have understanding of a person on a residential face-to-face versus being in a facility when you have someone like another staff person training you and showing you the ropes, and multiple individuals with multiple needs that you're gathering all that information much quicker than you would just, in sitting in someone's home at that point in time. So I agree with you there.
Yep.
Well, thank you, Craig, for coming on the podcast tonight. I know you have other stuff that you could definitely talk on for hours and hours, but I feel like we've covered a ton tonight, and we really want to say thank you for taking time. We know, obviously, as the president, you're a very busy man, so we appreciate your time tonight.
Well, I'm very, very thankful for the opportunity to do this, and things like this help to let more people know that there are resources out there to support them and to help them to support other people better. And that's part of my job, is to help people to know that there's support out there. So, if anybody wants more information on what we do, if I can give my website.
Yeah, absolutely.
Please.
The company's website is hrstonline.com. And you'll find information about a lot of the things that we talked about. And, our company is built on people who have worked in the field. Most of our employees have worked in the field directly providing some level of support or care for people with disabilities. So we have a personal investment in what we do each day. And it's not just a job or a business. that we have a mission behind what we do. So you can learn more again at hrstonline.com. And we're on Facebook, Health Risk Screening. If you just search Health Risk Screening on Facebook, and what else? LinkedIn, and I don't know, a couple of the other ones.
We'll find them.
So, give them all out while you can, because I trust to believe I forget all mine.
And so you can find us there. Yeah, we've got Twitter and Instagram, and I think if you just search Health Risk Screening, you'll find us on there too.
All right. Well, thank you, Craig. We hope to speak to you again very soon.
Sounds good.
Thank you, Doctor. It was awesome. Appreciate it.
Enjoyed it.
Hey, everybody. Thanks for watching this episode of the Friends for Life podcast here on YouTube. We'd really like to give a shout out again to Dr. Craig Escude for coming on and sharing all of his wonderful knowledge with us. If you can, go down below, hit that subscribe button. Also, we are on all the other podcast locations, iTunes, Stitcher, Spotify, and such. So if you can go to those, leave us a review, subscribe. That would be awesome. And we'll see you all next time.